Hi, welcome to our channel of IGNOU audiobooks. Indira Gandhi National Open University, School of Health Sciences, SOHS, Diploma Programmes, Postgraduate Diploma in HIV Medicine, PGDHIVM, MCMM 001 Basics of HIV Infection, Block-1 Epidemiology of HIV, Unit 1 Epidemiology, Global and National Scenario, 1.0 Objectives. On successful completion of this unit, you should be able to describe current global scenario of HIV estimates, define the current HIV estimates in India, and describe revised classification of states districts in India under NACPII. 1.1 Introduction. Acquired Immune Deficiency Syndrome, AIDS, was first described as a new, clinical entity in 1981. Initial reports were based on an unusual increase in the incidence of Kaposi's sarcoma and pneumocystis carinii pneumonia, PCP, among men who had sex with men, which were very rare at that time period. In 1981, the first 3 clinical descriptions published all described an epidemic of community-acquired pneumocystis pneumonia with oral thrush as well as chronic ulcerating, perianal herpes infections in previously healthy homosexuals from New York City, Los Angeles, and San Francisco. A little later, in June 1982, PCP was noticed among hemophiliacs. This elicited similar reports from France, the Caribbean, and Central America. In the United States, the disease was first called gay cancer, and then labeled gay-related immune deficiency because homosexual men first exhibited characteristic symptoms. In some areas in Africa, the disease was called slim or slim disease because of the profound wasting and the association of death with progressive weight loss and diarrhea. About the same time, pediatric immunologists noted more infants with unexplained immune problems. Acquired immunodeficiency syndrome, AIDS, is a disease of the human immune system caused by the human immunodeficiency virus, HIV. This has become one of the world's most serious health and development challenges. This condition progressively reduces the effectiveness of the immune system and leaves individuals susceptible to opportunistic infections and malignancies. Untreated, HIV disease is a chronic progressive process that begins with infection, is often followed by a primary HIV syndrome, and progresses in adults over a median period of more than 10 years to the late stage. AIDS. 1.2 Global Scenario of HIV Estimates. Since the first cases were reported in 1981, more than 25 million people have died of AIDS worldwide, and another 40 million are currently living with HIV/AIDS. While cases have been reported in all regions of the world, almost all those living with HIV, 97%, reside in low and middle-income countries, particularly in sub-Saharan Africa. At the end of 2001, an estimated 40 million people globally were living with HIV. Africa, the global epicenter, is the region with the largest epidemic. Sub-Saharan Africa is home to 70% of the people who are infected with HIV. It is also the region in which 4/5 of all AIDS deaths occurred. The sheer number of Africans affected by the epidemic is overwhelming. Next largest number of HIV-infected people live in South Asia and East Asia. While rates remain low relative to some other regions, well over 7 million Asians were infected by 2001, and HIV is clearly beginning to spread in earnest through the vast populations of India and China, in Eastern Europe and in Latin America and the Caribbean. Infections are concentrated in marginalized groups, though clearly not limited to them. In North America and West Europe, new combinations of anti-HIV drugs introduced in the mid-1990s continue to reduce AIDS deaths significantly, and also brought the epidemic under control. MV primarily affects those in their most productive years. In many parts of the developing world, the majority of the new infections were in young adults, with young women being very vulnerable. About 1/3 of the infected are between the age groups of 15-24. Most of them do not know that they carry the virus, though it is a slow-acting virus that can take a decade or more to cause severe illness and death. HIV has already cost the lives of nearly 14 million adults and children. HIV is transmitted to the child when a pregnant woman is infected with HIV, while mother-to-child transmission can be reduced by providing pregnant HIV-positive women with antiretroviral drugs and alternatives to breast milk, the ultimate aim must be effective prevention for young women so that they can avoid becoming infected in the first place. 1.3 UN Declaration, Progress Towards Realizing the Declaration of Commitment. Against the backdrop of growing concern about the impact of HIV/AIDS on societies, families and individuals, the United Nations held the 26th General Assembly Special Session on HIV/AIDS in New York from 25 and 27 June 2001. At this session, a declaration of commitment was adopted by all the member states of the United Nations, the first comprehensive set of principles and targets ever adopted internationally for confronting HIV/AIDS. The Declaration of Commitment on MVI/AIDS was a potential watershed in the history of the HIV/AIDS epidemic. It established, for the first time ever, time-bound targets to which governments and the United Nations may be held accountable. 189 countries adopted the declaration. More countries recognized the value of pooling resources, experiences and commitment by forging regional initiatives to combat the epidemic. The African countries pledged to allocate at least 15% of their resources for the improvement of the health sector during the special Abuja summit in 200 Additional resources were brought by the new Global Fund to fight AIDS, tuberculosis and malaria, $616 million, about two-thirds of which is earmarked for HIV/AIDS. Governments and donors have pledged more than $2.1 billion to the fund. The global response expanded significantly in 2 to 3 years. Spending, domestic and external, on HIV/AIDS programs in low and middle-income countries increased again in 2003, notably in sub-Saharan Africa. Dozens of national AIDS coordinating bodies have begun extending antiretroviral and other AIDS-related medications to their citizens. But, at the moment, these developments do not match the region's epidemics in scale or pace. But the world lags furthest behind in providing adequate treatment, care and support to people living with HIV/AIDS. Fewer than 4% of people in need of antiretroviral treatment in low and middle-income countries were receiving the drugs at the end of 2001, and less than 10% of people with HIV/AIDS have access to palliative care or treatment for opportunistic infections. Unaffordable prices remain the most commonly cited reasons for the limited access to antiretroviral drugs. Insufficient capacity of health sectors, including infrastructure and shortage of trained personnel, are also major obstacles to health service delivery in many countries. At this juncture, the World Health Organization, WHO, and UNAIDS spearheaded a bold initiative to roll out antiretroviral treatment to 3 million people in areas of most need by the end of 2005. 1.3.1 The 3x5 Initiative. The problem is urgent. 30 million people have died in 2 decades. 40 million more people are infected. In poor countries, 6 million people with HIV/AIDS need immediate ART. Less than 8% get it. Worst hit is sub-Saharan Africa. With 28.5 million people infected, HIV/AIDS has destroyed communities, healthcare systems and put a shadow upon the future of entire countries. About the 3x initiative. The 3x5 initiative, launched by UNAIDS and WHO on World AIDS Day 2003, was a global target to provide 3 million people living with HIV/AIDS in low and middle-income countries with life-prolonging antiretroviral treatment, ART, by the end of 2005. It was a step towards the goal of making universal access of HIV/AIDS prevention and treatment accessible for all who need them as a human right. The goal: universal access to antiretroviral therapy for all living with HIV/AIDS. The 3x5 target: treating 3 million people by 2005. Progress Report 3x5 Initiative. Since the launch of the 3x5 initiative by WHO, coverage of antiretroviral therapy, ART, in these countries has more than doubled, increasing from 400,000 to approximately 1 million people receiving treatment at the end of June 2005. Till June 2005, 14 countries provided ART to at least 50% of those who need consistent with the 3 by 5 target. The estimate of approximately 1 million people on treatment falls short of the milestone of 1.6 million set in the WHO UNAIDS 3 by 5 strategy for June 2005. Current data and trends indicate that providing ART to 3 million people by the end of 2005 will be unlikely. Although less than what is needed, an estimated $27 billion are available or have been pledged for HIV/AIDS globally from all sources for the 3-year period 2005-2007. At the same time, substantial political commitment to moving forward is evident in the many countries that have translated the global 3 by 5 target into ambitious but feasible national treatment targets. Figure 1.1, estimated number of people receiving ARV therapy and percentage coverage in 20 countries with the highest unmet need. June 2005. In 2007, advances in the methodology of estimations of HIV epidemics have resulted in substantial changes in estimates of numbers of persons living with HIV worldwide. The estimated number of persons living with HIV worldwide in 2007 was 33.2 million, 30.6 to 36.1 million, a reduction of 16% compared with the estimate published in 2006, 39.5 million, 34.7 to 47.1 million. UNAIDS WHO, 2006, the single biggest reason for this reduction was the intensive exercise to assess India's HIV epidemic, which resulted in a major revision of that country's estimates. Important revisions of estimates elsewhere, particularly in sub-Saharan Africa, also contributed. As of December 2008, approximately 4 million people in low and middle income countries were receiving antiretroviral therapy, a 10-fold increase over 5 years. World Health Organization, United Nations Children's Fund, UNAIDS, 2009. According to 2009 data, the current number of people living with HIV is 33.3 million. 2.6 million people were newly infected with HIV/AIDS and 1.8 million AIDS deaths were reported in 2009. Since 1999, the year in which it is thought that the epidemic peaked, globally, the number of new infections has fallen by 19%. Of the estimated 15 million people living with HIV in low and middle-income countries who need treatment, today, 5.2 million have access, translating into fewer AIDS-related deaths. Regional HIV and AIDS statistics and features. 2009. Look at the screen. We are now in the 4th decade of the AIDS epidemic. Now the epidemicis contained it has halted and begun to reverse the spread of HIV. As per Millennium Development Goals 6.a, the new UNAIDS vision is zero discrimination, zero new HIV infections, and zero AIDS-related deaths through universal access to effective HIV prevention, treatment, care and support. J1.4 National Scenario and Current HIV Estimates in India. The human immunodeficiency virus, HIV, was first found in India in Chennai in 1986. Demographically the second largest country in the world, India has also the third largest number of people living with HIV/AIDS. India's initial response to the HIV/AIDS challenge was in the form of setting up an AIDS task force by the Indian Council of Medical Research, ICMR, and a National AIDS Committee headed by the Secretary, Department of Health. In 1992, the government launched the first National AIDS Control Programme, NACPI. NACPI was implemented during 1992 to 1999 with an objective to slow down the spread of HIV infections so as to reduce morbidity, mortality and impact of HIV epidemic in the country. To strengthen the management capacity, a National AIDS Control Board, NACB, was constituted and an autonomous National AIDS Control Organization, NARCO, was set up to implement the project. In November 1999, the NACP Illinois was launched with the objective to reduce the spread of HIV infection in India and to increase India's capacity to respond to HIV/AIDS on a long-term basis, i.e., the focus shifted from raising awareness to changing behavior, decentralization of program implementation at the state level and greater involvement of NGOs. Then, the National AIDS Control Programme Phase 3, 2007 to 2012, was launched with the goal to halt and reverse the epidemic in India over the 5-year period, as per the provisional HIV estimate of 2008 to 2009, there are an estimated 22.7 lakh people living with HIV/AIDS in India. The HIV prevalence rate in the country is 0.29%, 2008 to 2009. 6 high prevalence states contribute more than 60% of HIV-infected people. Women constitute 39% and children 3.8%. The graph above shows the declining prevalence rates from 0.45 in 2002 to 0.29 in 2008. The reasons for this decline in prevalence rates are due to 1. Better awareness among the people. 2. The spread of HIV/AIDS is associated with behavior. Generating awareness and changing behavior can therefore reduce its transmission. 3. Good prevention strategies that are being implemented. Prevention strategies include targeted interventions for high-risk population groups including long-distance truck drivers, female, commercial sex workers, tourists, slum populations, factory workers, men having sex with men and migrant workers. Some examples of the targeted intervention programs implemented in Tamil Nadu are intervention along the highway path, women in prostitution, WIP, slum intervention program, SIP, tourist and women in prostitution, TWIP, industrial intervention program, LIP, men having sex with men, MSM, migrants intervention program, MIP. 2. Comprehensive sex education for young people is an essential part of HIV prevention. This should include training in life skills such as negotiating healthy sexual relationships, as well as accurate and explicit information about how to practice safer sex. Counseling on safer sexual behavior through media campaigns, social marketing, peer education, and small group counseling. 3. Condom promotion is being widely implemented as a prevention strategy. Condoms, if used consistently and correctly, are highly effective at preventing HIV infection. Free supply of condoms at strategic locations and hot spots and through targeted intervention programs is being widely practiced. Condoms should be made readily and consistently available to all those who need them. 4. Treatment of STI helps a lot in reducing HIV infections. The integrated counseling and testing centers helps more people to get tested and make them aware of their infection and thereby reducing further transmission of the virus from the infected people. 6. Needle exchange programs have been shown to reduce the number of new HIV infections among injecting drug users. These programs distribute clean needles and safely dispose of used ones, and also offer related services such as referrals to drug treatment centers and HIV counseling and testing. 7. Using safe blood and blood products and implementing blood screening for blood-borne pathogens in all blood banks in India. Targeted interventions, i.e. provision of risk reduction measures such as information, condoms, treatment for STIs, for high-risk groups, FSWs, MSM, IOUs, will remain the mainstay of the response under NACP 3. Revised estimates for India HIV epidemic. The estimate for India was based primarily on anonymous testing data from public clinics for prenatal care and for patients in high-risk groups or with sexually transmitted infections. Although the number of surveillance sites was expanding, the data was inadequate. This method identified high prevalence areas as defined by a rate of HIV positivity of more than 1% among women visiting prenatal clinics and a rate of more than 5% among patients visiting clinics for sexually transmitted diseases, and monitored trends in the rate of infections over time. Surveillance also established that MV transmission is primarily sexual, except in northeastern India, where there is a high rate of spread through injection drug use. But direct extrapolation from sentinel surveillance data provided an inaccurate national estimate. In 2006, the Joint United Nations Programme on HIV/AIDS, UNAIDS, and the World Health Organization, WHO, estimated that 5.7 million people in India were infected with the human immunodeficiency virus, HIV, a figure that captured wide attention and raised the possibility that India had more infected people than any other country. In 2007, however, the estimate was revised downward to 2.5 million, range 2.0 million to 3.1 million, a revision so large that it reduced by nearly 10% the estimated number of people living with HIV globally and reinforced ongoing concerns about the validity of methods for producing such epidemiologic estimates. These estimates are more accurate than those of previous years, as they are based on an expanded surveillance system and a revised and enhanced methodology. The Indian government has greatly expanded and improved its surveillance system in recent years and increased the population groups covered. In 2006, the government created 400 new sentinel surveillance sites and facilitated National Family Health Survey 3, NFHS 3, which is a population-based survey and which was conducted in 2005 and 2006 with support from the U.S. Agency for International Development and other organizations. D released in October 2007. The revised estimates have been possible largely due to three main factors: a new population-based survey which included an important HIV component, expanded sentinel surveillance which included groups at higher risk of HIV infection, and revised methodology to make the best use of the new data sources. The revised estimates in 2007, following the first survey of HIV among the general population, UNAIDS and NARCO agreed on a new estimate, some 2.5 million, 2 million and 3.6 million people were living with the virus, and that HIV prevalence among adults was around 0.34%. The epidemic in India is concentrated among high-risk group populations and is heterogeneous in its spread. The overall HIV prevalence among different population groups in 2008 to 2009 is high-risk groups IGNOU 9.2%, MSM 7.3%, FSW 4.9%, and STD clinic attendees 2.5%, and low prevalence among ANC clinic attendees 0.49%. The primary drivers of HIV epidemic in India are unprotected paid sex, unprotected sex between men, and injecting drug use. It is estimated that there are 12.61 lakh female sex workers, 3.5 lakh men who have sex with men with high risk, and 1.9 lakh injecting drug users in India. Routes of transmission. Information from persons testing positive for HIV at the integrated counseling and testing centers across the country during 2009-2010 shows that 87.1% of HIV infections are still occurring through heterosexual routes of transmission. The major route of transmission of this infection is through heterosexual route. Parent-to-child transmission accounts for 5.4% of HIV cases detected, men who have sex with men, 1.5%, contaminated blood and blood products, L%, and injecting drug use account for 1.6%. In the northeastern region, injecting drug use is the major cause for the epidemic spread. Stable HIV epidemic in India. HIV estimates derived using globally comparable methods and findings from the Independent Impact Assessment study show that the National AIDS Control Programme is progressing steadily towards the objective of halting and reversing the HIV epidemic in India over the period 2007 to 2012. Available evidence on HIV prevalence and future statistical projections shows signs of stabilization of HIV epidemic in India at national level. 1.5 Classification of status districts in India under NACP. The method of classification of prevalence, high, moderate, low, was based on state-wise prevalence among ANC and high-risk groups in the previous years. However, as per the NACP3, National AIDS Control Programme Phase I, classification is now done based on prevalence in the districts rather than state-wise, for the purpose of planning and implementation of NACP-III. All the 611 districts in the country were classified into 4 categories based on HIV prevalence in the districts among different population groups from the HIV Sentinel surveillance data from the last 3 years 2003, 2004 200s, the epidemiological profile, risk, and vulnerability. The classification of districts is as follows. Category A, more than 1% ANC PPTCT prevalence in district in any time, and in any of the sites in the last 3 years. Category B, less than 1% ANC PPTCT prevalence in all the sites during last 3 years with more than 5% prevalence in any HRG, high-risk groups, site. STD FSW MSMLIDU. Category C, less than 1% ANC prevalence in all sites during last 3 years, with less than 5% in all HRG sites, with known hotspots, migrants, truckers, large aggregation of factory workers, tourist etc. Category D, less than 1% ANC prevalence in all sites during last 3 years, with less than 5% in all HRG sites with no known hotspots or no or poor HIV data. According to the revised district categorization, there are 156 Category A districts and 39 Category B districts, total of 195 districts, that require priority attention. Out of these, 156 Category A districts, 122 districts fall in the 6 high prevalence states of Andhra Pradesh, Karnataka, Tamil Nadu, Maharashtra, Manipur and Nagaland, while 34 districts fall in the low-burden states of North India. Among the Category B districts, besides 5 districts in Tamil Nadu, rest of the 34 districts fall in low-burden states. These districts have a great potential for the spread of HIV epidemic, and if sufficient attention is not given, they may progress to Category A. The fact that 68 high-prevalence districts were found in the low-burden states suggests the heterogeneous mode of spread of HIV epidemic in India and brings to focus the newly emerging pockets of HIV infection in the country. In comparison to the earlier district categorization, 33 new districts have entered Category A, while 17 districts which were in Category A previously have moved out. 21 out of 33 districts that have entered Category A are in the low-burden states. Similarly, 9 new districts have entered Category B, while 17 districts which were in Category B previously have moved out. 1.6 Summary: HIV epidemiology continues to evolve. Although considerable progress has been made in reducing the impact of the HIV epidemic, certain populations, especially racial and ethnic minorities, continue to bear a disproportionate burden. Survival differences among racial and ethnic minorities might be attributed in part to late HIV diagnosis and differential access to care. Comprehensive and culturally sensitive approaches to prevention, treatment, and care are needed to reduce disparities in infection rates and disease progression. Thank you. Subscribe to our channel for more updates, and we will see you with the next chapter.